So the next thing I'd like to move on to is sort of number 3 here, which is coming up with an assessment and making a diagnosis of major depression in a population of patients that have a serious illness like cancer. So I want to define this problem, and every good talk should have a little bit of epidemiology. And so patients with serious illnesses, if you take all comers, things with heart failure, cancer, dementia, anywhere from, if you look in the literature, from 25% to 75% of patients will experience mood disordered symptoms towards the end of their life. And if you look at the overall WHO data, that major depression is the leading cause of disability over patients' life years. And when comorbid with a serious chronic disease like cancer, this is associated with significant reduction in patients' quality of life and a significant increase in the cost of their health care. And major depression affects roughly about 10% of patients with cancer, and this number to me always seems pretty low, but the literature on cancer, on depression and cancer, isn't actually that great. And in patients who have anxiety, pain, fatigue, and they'll generally develop worsening function as a result of having depression. This increases the risk for suicide in patients with cancer, and actually poor outcomes for patients with cancer because they're less likely to adhere to their anti-cancer therapies if they're feeling more down and depressed about it. So some of the risk factors for our patients, if we're identifying somebody who we're seeing who has cancer or has something like heart failure, what are the risks that they may get depression? Well, they've got an advanced disease. They may have spiritual or existential suffering, wondering why God has caused this to happen to them. And patients that have more spiritual distress or anxiety or anger in a spiritual context or a religious belief structure are more likely to develop major depression. Our patients oftentimes have uncontrolled pain or other symptoms that make their mood worse, can develop physical impairment, inability to get out of bed, can become chair or bed bound. They're oftentimes getting medications that cause worsened mood symptoms, so chemotherapy affects cognitive function. A lot of our patients may have comorbid or active substance abuse, alcohol use. Unfortunately, patients of female gender are more likely to develop major depressive disorder. They've had depression in their younger life or other mood symptoms or like a psychotic disorder. Getting cancer doesn't make having depression better, and having depression doesn't make cancer better. And so this is another risk factor. And for a lot of our patients in low and middle income countries and here in the US and other developed nations, actually just lack of access to good mental health care services is a risk factor for having depression in the context of a serious illness. So if we look across just the general population, about 2% of men over their lifetime are at risk for developing a major depressive disorder, 3.3% of women. All of us, it's around 3%. Patients that have had a major depression, about 4% of the population will likely develop chronic depressive symptoms or dysthymia, sort of more of a mood structure that looks more like depression throughout their lifetime. This is a relatively prevalent disorder for most of the general population, irrespective of having something like cancer. But one of the things that's always sort of hard is sort of getting the context of what this means. And when I talk about depression, I'm generally talking about the DSM or Diagnostic and Statistical Manual's definition of a major depressive disorder, which means that that patient is having some sort of dysfunction in their life, be it at home, at work, in interpersonal relationships, in taking their medicines and adhering to medicines. So that mood symptom or that disorder is causing dysfunction in their life, which is different than, say, for example, somebody who has just received a diagnosis of stage 4 cancer or received a diagnosis of a serious illness like HIV, for example, who may become sad or have some grief symptoms that are transient, last a few days to a week, but cause distress. And that's not the same thing as having a disorder that needs further treatment. And in our setup, patients and families and even other practitioners will use sort of the terminology of depression, in quotes, meaning that somebody's unhappy, like my sports team didn't win the championship and I'm really depressed. Well, that's not the same thing as major depression. Somebody may also say, I'm really depressed that I just got a diagnosis of cancer. And that sadness and that change stress that comes with a diagnosis or a change in treatment can lead to a significant burden in distress or symptoms. And that can eventually lead to somebody having a major depressive disorder, particularly if they're biologically at risk for it, like for our patient whose mom and maternal uncle probably had a major depressive disorder. And I bring this up because not everybody needs to be treated for having symptoms of sadness or hopelessness. Some people, this is a normal reaction to getting a bad diagnosis or finding out that your treatment's not working. But for a lot of people, these symptoms only last for a brief period of time, for a few days to maybe a week. But when those symptoms start lasting for weeks on end and start causing dysfunction, that's when we need to start identifying, how do we identify the patients who really need treatment? So again, the hard part with, in this patient population, particularly folks that have cancer, is that teasing out who that patient population is a little bit hard because there's kind of some wide variation in the prevalence estimates, particularly in cancer. So again, 3% of patients overall in their lifetime might get depression, but if you have advanced cancer, that 3% can jump way up to even something like 58 to 60% of patients with cancer may develop depression, severe major depression, during the course of their illness. Thus, it's important to figure out, how do we actually identify or screen patients for this? I want to step back and say that, again, part of the challenge with this is that these folks have a really bad illness, and that illness can have a lot of symptoms. It can have nausea, fatigue, weight loss, pain, difficulty in function. And thus, it can be really hard to tease out that diagnosis and separate the physical symptoms associated with having cancer from some of the psychological symptoms. And what I mean by that is that most people who have depression are sad, or they have anhedonia, meaning they get no pleasure out of the things that they used to like to do. Versus some of the somatic symptoms, or what we call the neurovegetative symptoms, so losing weight, not having any appetite. Some people eat too much, being tired all the time, having poor or interrupted sleep, having worsening pain symptoms, not being able to focus or concentrate on activities, or some cognitive dysfunction, or almost some pseudo-dementing type of dysfunction in the brain. And because cancer patients will lose their appetite, they will lose weight, they'll have fatigue, they'll get difficulty with their sleep, they'll have pain. It's hard to know, are those somatic symptoms just cancer, or is this related to a mood disorder? And that can be really hard to tease out clinically for a patient. Part of the fun that I have in sort of the art of doing this is figuring out what is going on here. So the way that I like to sort of parcel this is really that the psychological symptoms here on the right side of your screen, really this continuous feeling of sadness, patients being tearful, really no motivation to do the things they like to do, or the anhedonia, are really much more specific to a diagnosis of depression in patients with cancer, as opposed to those physiologic symptoms or the somatic symptoms like changes in sleep, appetite loss, weight gain, aches and pains aren't really as helpful, because that's probably most likely due to their cancer. It's not making the mood any better though. So when you're trying to contextualize this, we use this framework of the DSM-5 for making a diagnosis, but it's complicated when you've got folks that have cancer. Again, if these symptoms have been going on for several weeks, that can tell you that, okay, there's probably a problem. If there's dysfunction, that probably is telling us that there's a diagnosis of depression. But this is really complicated. There's a lot of diagnostic criteria. And I'm kind of a simple person, and I prefer to find a simple way to make this diagnosis. Because that last slide was really busy with all of those different diagnostic criteria. So a screening tool for diagnosing major depression in cancer patients is really helpful. And the American Society of Clinical Oncology, or ASCO, has come up with a framework here in the United States and in Canada for how we sort of assess depression in cancer patients. And really the way that we do this is to use something called the Patient Health Questionnaire 2, or the PHQ-2. There's an expanded version I'll talk about in a minute called the PHQ-9, or the Patient Health Questionnaire 9, which means there's 2 questions on one and 9 questions on the other. The 2-question form I find is the most helpful as a basic screening tool. And it really asks the psychological questions about major depression. So over 2 weeks, have you been bothered by little interest and pleasure in doing things you normally like to do? And is this going on for more than half of the days of the week, so 3 or 4 days a week? Or is it almost every day, 7 days a week, that this is happening? And are you feeling down? Are you feeling sad, depressed, hopeless? And again, is this happening more than half of the days of the week, or is it happening every day? And the scoring system for this, if patients score a 2 or 3 or higher on the PHQ-2, this has a 97% sensitivity for detecting most likely a depressive disorder, and a 93% what we call negative predictive value, meaning that if the screening is negative, it's highly unlikely that that patient has depression. You move on to talking about other things. And so I find this is really helpful at the bedside. Just ask these 2 questions, find out how many days of the week this is going on. And if they screen positive, then to move on to doing the PHQ-9, which are 9 questions. This is really the diagnostic criteria. This can be done relatively rapidly at the bedside. Patients actually can be handed a piece of paper and fill this out. And what I really try to focus on with this is really asking the last question, which is how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people in your life? And this is the dysfunction question, meaning are people having a lot of difficulty or extreme difficulty with these symptoms in their life? And that tells me that there's dysfunction and that we need to do something about those symptoms. But the scoring tool also helps to give me a very specific number, a quantitative way of then, once I implement a treatment, if the scores get better, people are generally feeling better. And that tells me that my treatment's actually helping. So again, the level of dysfunction are these very severe difficulty, extreme difficulty tells me that there's disorder. If there's disorder, then that tells me that I need to implement a treatment modality. And so the scoring system here is if you get a score, let's say less than an 8, patients usually have mild symptoms. And we generally just provide more support, talk about how they're doing with their illness, focus on some of the things like pain or other symptoms that might be making their mood worse. But if patients have more moderate to severe symptoms, so scores 8 or higher, or scores greater than 20, then those patients really need some sort of medication or psychotherapy to really focus on trying to address those severe symptoms related to depression.